Good evening, everyone. A very warm welcome to our virtual Grand Rounds in Radiation Oncology lecture. Many thanks for joining. I know it's December time, it's cold outside, Christmas presents might have to be arranged. So thanks for joining and taking some time for our virtual Grand Rounds lecture. At the beginning, a very quick introduction. You know our format quite well. We aim to present you the latest clinical research and science presented by the top speakers in our field, and that in a very interactive format. So please use the questioning and answering functionality to ask questions. That's what it's made for, to ask questions to the PIs of the respective trials. This is happening once in a month, usually the first Wednesday between 5 and 5:30, and as always, we will finish on time. I'm very grateful for the endorsement and support by our societies, by the ESTRO Society, Swiss Radiation Oncology, and the German Society for Radiation Oncology. And also a reminder that all the webinars are being recorded on the web page of our virtual ground lecture. So if you have missed any of the fantastic presentations before, visit our web page and have a look and read on them. Today, we have a very important topic, preoperative chemoradiotherapy for resectable gastric carcinoma. A study, a randomized clinical trial published in the New England Journal in September 24. And you see that Professor Karin Haustermans will be joining us this evening and presenting this trial. She will not only present this individual trial, which is already super important, but also will try to put this clinical trial into the context of recent developments in the field of gastric or gastroesophageal cancer. In particular, the TOPGEAR, which will be the topic of this talk, but in particular also the critics in the ESOPAC trial. Keep in mind that ESOPAC has only been reported in abstract format at the ASCO meeting. We still have to wait for the final publication. As mentioned before, I have a pleasure and honor to announce the speaker of this evening, Professor Karin Haustermans, everyone known in the field of radiation oncology, multimodality treatment for GI malignancies. She's the medical director of the Proton Therapy Center at the University of Leuven. She's there in the board of the Comprehensive Cancer Center of the University Hospital. She has had many leaderships and has many leadership positions in the EORTC and in the ESTRA. And I just want to mention one of the most important awards, the Brewer Medal, which has been given to her in 21. Karin, many thanks for joining. We're looking forward to the presentation of the results, but in particular on the interpretation of the TOPGEAR trials and how the field of radiation oncology is moving forward in upper GI malignancies. Karin, the floor is yours.
Thank you, Matthias, for your very kind introduction. I chose Revving Up Gastric Cancer Care as my general title today, but I indeed will focus mainly, but not only, on the TOPGEAR trial. So TOPGEAR, as Matthias mentioned, is a randomized phase 3 trial of perioperative chemotherapy with or without preoperative chemoradiotherapy for resectable gastric cancer. The trial was presented at ESMO this year, and the PI of the study and the presenter was Trevor Leong from Melbourne in Australia. And I use some of the slides he also used during his presentation at ESMO. So what's the background of the TOPGEAR trial? Well, we are all aware of the big trials on perioperative chemotherapy. The first one and the oldest one is the MAGIC trial, which showed an advantage of perioperative ECF versus surgery alone. The MAGIC was followed by the FLOT4 study, a German trial, which compared ECF or ECX versus FLOT in the perioperative setting. And you can clearly see here that FLOT is superior to ECF, ECX in the perioperative treatment of gastric cancer. Then we have the trials on post-op chemoradiotherapy, the intergroup trial, which is an old trial. It looked at patients post-surgery and randomized between no further treatment or chemoradiation combined with 5-FU folinic acid, an old-fashioned way of treating in the post-op setting. But anyway, this trial showed the superiority of adjuvant chemoradiotherapy in this setting. So post-op chemoradiotherapy became a standard for quite a long time, especially in the States, but then was followed by the CRITIC study, and the critics looked at the standard ECX at that time, so the MAGIC perioperative, versus pre-op ECX, followed by surgery, followed by post-op chemoradiation. And that was a long course of radiation combined with capecitabine. And as you can see on the slide, there was no significant difference in overall survival. But no significant difference in overall survival does not mean that perioperative chemotherapy is superior to post-op chemoradiation after pre-op chemo and surgery. So that was the background of the TOPGEAR trial. And in the TOPGEAR trial, we chose for a preoperative chemoradiotherapy because we know from other studies that preoperative chemoradiation is better tolerated. So we have a higher chance that all patients receive the intended treatment. We can expect tumor downstaging, and this will lead to more R0 resection rates. Pre-op treatment is applicable to more patients compared to post-op treatment, especially in gastric cancer. Very few patients are able to follow the post-op treatment, or the full post-op treatment, around only 50%, so that's very low. It also provides a window of observation for metastatic disease. So during the pre-op treatment, patients are restaged after the pre-op treatment before they go to surgery. If they develop metastasis before the surgery, surgery can be avoided. And we also know, more or less, that preoperative chemoradiation is the standard of care for esophageal cancer. Today, it still certainly is the standard of care for squamous cell carcinoma, adenocarcinoma. There is some doubt, and I'll come back to that. So the hypothesis of the trial was that the addition of preoperative chemoradiotherapy to perioperative chemotherapy would improve overall survival compared to perioperative chemotherapy alone in patients undergoing surgery for resectable gastric cancer. So this was the design of the study. So eligibility criteria were a resectable adenocarcinoma of the stomach or the GE junction. And this included severe type 2 GE junction cancers with 2 centimeters or less of the esophagus involved, and severe type 3. And this is also important when we look at the results of the ESOPEC trial. Stage 1B to 3C, so T3, T4, and or node-positive disease. The standard arm, the perioperative treatment with chemotherapy, was ECF at the start of the trial, but during the trial, the results of the FLOT trial became available, and so the ECF was adopted to FLOT. The study arm was a combination of chemotherapy and chemoradiation in the pre-op setting. Also there, ECF was replaced by FLOT, followed by surgery, followed by more chemotherapy, either ECF or FLOT. Primary endpoint, overall survival. Secondary endpoints, progression-free survival, pathological complete response rate, toxicity, including surgical complications, and quality of life. The sample size, the trial was designed to detect a 24% reduction in death rate. for pre-op chemoradiation, assuming a 5-year survival of 40% for perioperative chemotherapy, because at the time the trial was designed, we had the results of the MAGIC, but not of the FLOT. And so this corresponds to a 10% improvement with preoperative chemoradiation to 50%. And to obtain this, 570 patients were required to achieve 80% power with 95% confidence. All analyses were performed on an intention to treat basis, and additional safety analysis of adverse events were undertaken among patients commencing protocol therapies. All tests were two-sided and unadjusted for multiple comparisons. The trial started to recruit in September 2009, so a long time ago, till May 2021. 574 patients were enrolled from 70 sites across 15 countries in Australia, New Zealand, Europe, and Canada. 288 were randomized to perioperative chemo alone and 286 to perioperative chemo plus pre-op chemoradiation. Follow-up for survival was curtailed and database was frozen for final analysis in June this year. If we look at the patient characteristics, they are very well balanced between the two arms, but also something that you should keep in mind is that more than 30% of the patients in TOPGEAR had the GE junction adenocarcinoma. If we look at treatment compliance, we see that the treatment compliance, especially in the pre-op part of the study, was very high and comparable between the two arms. So the pre-op chemo followed by pre-op chemoradiation was as well tolerated as the pre-op chemo alone. If we look at the post-op chemotherapy, we see that only 59% of the patients that underwent surgery received post-op chemotherapy. So there is a tendency that patients that received pre-op chemo alone had a somewhat higher tolerance for post-op chemo. But if we look at, and also that's the case if we look at all randomized patients. 90% of the patients received chemoradiotherapy and 92% completed the 45 grade, that was the dose prescribed in the study arm. If you look at the number of patients receiving surgery, that was very high, 80% of the randomized patients and comparable in both arms. If we look at the surgical and pathological outcome, we see that there was significantly more pathological downstaging in the group of patients that underwent pre-op chemoradiation versus pre-op chemo alone. If we then look at overall survival, the primary endpoint, we see that there is no difference between the perioperative chemotherapy versus the pre-op chemoradiotherapy. If you look at the numbers or the percentages, you see that the 3-year overall survival in this disease is still just above 50%. So we have a lot to gain and to improve the outcome in these patients. And at 5 years, of course, it's even lower. It's around 45%. 3-year progression-free survival, again, comparable between the two arms, and 3-year progression-free survival is below 50%. If we look at the pre-specified subgroups, we don't see a benefit of either treatment in one or another subgroup. If we look at toxicity, very comparable between the two arms. So the pre-op chemoradiation did not lead to an increase in toxicity. If we look at surgical morbidity, no difference between the two arms. So again, pre-op chemoradiation did not lead to more surgical morbidity. So the conclusions from TOPGEAR are, first of all, it's the first randomized phase 3 trial of pre-op chemoradiotherapy for gastric cancer. Pre-op chemoradiation does not affect rates of curative resection and is not associated with an increased toxicity or surgical morbidity. We do see that preoperative chemoradiation increases the PCR rate and tumor downstaging. Adding preoperative chemoradiation to perioperative chemo does not improve overall survival in resectable gastric and GE junction adenocarcinoma. And of course, this was a joint effort, and so lots of trial groups were involved from the different countries, and of course, a big thank you to the patients and the families. And as Matthias mentioned, at the time the TOPGEAR trial was presented at ESMO, at that time the paper came out in the New England Journal of Medicine. So it was pre-planned to have these two together. And that could have been a message for the ESOPEC trial as well. This is a very interesting news and views article on the TOPGEAR trial. It is written by a surgeon, and I really encourage you to read it because it's interesting. It's a surgeon explaining that we should still consider chemoradiotherapy in GE junction and gastric cancer, and he's given many good reasons why we still should consider this. And this is not just a surgeon, this is a big name from MD Anderson. So what does he say? Well, pre-op chemoradiotherapy leads to a higher RZ resection rate. So maybe we should more carefully assess our patients and evaluate our patients preoperatively. And then maybe we should add chemoradiation for those patients at risk. We see a higher PCR rate. So there is a potential for cure in inoperable patients if we add pre-op chemoradiation. And he also makes a good point. He said maybe we should look into total neoadjuvant treatment, including radiotherapy, like we do in rectal cancer, for instance, instead of perioperative chemo only. And then we can consider radiotherapy in patients unable or unwilling to undergo FLOT. Because those who are familiar with FLOT, it's not sugar water. It's a very toxic chemotherapy. And then, yeah, in the TOPGEAR, there was no role of immune checkpoint inhibitors, or it was not included in the design because in 2009, these simply did not exist and were not used at all. But there again, we have to be careful because we see that there is no added value of immune checkpoint inhibition with chemotherapy. We are still awaiting the results of Matterhorn and Dante, but maybe if we combine with radiotherapy, there might be a benefit of immune checkpoint inhibitors, and the author is also the PI of a phase 1 trial combining these in gastric cancer, and that's published in the Red Journal, but it's only a phase 1 with 24 patients. This brings me to the ESOPEC trial, which was presented at ASCO, where patients were randomized between it's a German trial, so patients were randomized between perioperative FLOT. The FLOT schedule actually came originally from Germany, versus the neoadjuvant chemoradiation like we know from the CROSS. So only to 41.4 gray. In the TOPGEAR trial, we used 45 gray, combining with paclitaxel carboplatinum, 5 cycles in 5 weeks, followed by surgery and no post-op treatment. today, the standard is that patients that do not obtain a pathological complete remission should receive adjuvant immune therapy, but this was not part of the ESOPEC trial. Histology, adenocarcinomas, esophageal cancer, according to the TNM7. This is also an important point because in TNM7, the Sievert-3 was an esophageal carcinoma, while in TNM8, a Sievert-3 is a gastric cancer. Clinical stage, locally advanced disease, and then the exclusion criteria, one of them is gastric cancer, while in TNM8 today, gastric cancer is included in ESOPEC, and then metastatic disease or squamous cell carcinomas. Primary endpoint, overall survival. Secondary endpoints, progression-free survival, post-op pathological state, post-op complications, and then adverse events, recurrence-free survival, site of tumor recurrence, quality of life, but these are not yet reported. The intention to treat analysis of overall survival in all randomized trials was planned according to the statistics, and the sample size planning was to show superiority of FLOT. So that's in contrast to TOPGEAR versus CROSS for overall survival at one-sided significance level of 2.5%. Assumptions on 3-year overall survival rates, CROSS 55%, FLOT 68%, so higher than the original results, certainly for FLOT. 280 events needed for power of 90%, and in total 438 patients were needed. The trial accrued very fast, so from 2016 to 2020, that's also in contrast to TOPGEAR, which started in 2009. It was a German trial, 25 sites in Germany, 221 patients randomized to FLOT, 217 to CROSS, follow-up until November 2023, and stratified for clinical end stage and trial site. And these are the results. If you look at the results, CROSS is statistically significantly inferior to FLOT. Now, if we look at the 3-year overall survival rate, you might remember the trial was designed for a much higher, about 10% higher 3-year overall survival rate for the FLOT and also for the CROSS. There the difference was somewhat smaller. I think it was 55% for CROSS. So the results obtained are lower than what they actually estimated in their statistical design. And again, if you look at these data, we are not there yet. And we are only at 50% 5-year overall survival in the FLOT arm and a very low 5-year overall survival in the CROSS arm. And we are all trying to understand why it is so low. If we look at patients that started neoadjuvant treatment, there is a first strange finding, namely patients randomized to CROSS. Only 90.3% actually started with CROSS. So even before they started treatment, something happened in 10%, which is a lot. If we look at the percentages that completed neoadjuvant treatment, we see that's only 67.7% in the CROSS group. Remember the numbers in the TOPGEAR? It was 90% or more. If we look at the percentages receiving neoadjuvant treatment plus surgery, that's comparable, a little bit lower in the CROSS. Adjuvant treatment was only prescribed or given in the FLOT arm, and here we see it's 63.3%. So remember, again, around 50% because only 52% completed their adjuvant treatment. So again, showing that administering chemotherapy in patients with gastric or GE junction cancer after surgery is not obvious. And then another strange finding. If we look at the pathological complete remission in this study, first of all, it's low, but more striking, it's higher in the flood group than in the cross group. So to my knowledge, this is the first trial that shows an inferior pathological complete remission for chemoradiation compared to perioperative chemotherapy. So question, why? There is no QA performed in the trial. If you look in the protocol at the guidelines to delineate the target volume, the least to say is that it's old-fashioned. Also, the techniques used or the techniques that were allowed to be used are what we would call today old-fashioned. So the QA for radiotherapy in this trial can certainly be questioned. And if we compare with the TOPGEAR trial, where the first the first 5 patients of all sites were pre-treatment checked for delineation and isodose distribution, and then every 3rd patient in the trial. So very extensive QA, and here no QA at all. If we also look at why is the completion rate so low in the cross trial, only 67% of the patients received cross, while it was only 41.4 gray. If you discuss with the co-PI from Radiation Oncology, he told me that it's actually chemotherapy that was not given according to the protocol, because in Germany, that's what he told me, in Germany, radiation oncologists administer the chemotherapy when it is concomitant with the radiotherapy, and they are scared of side effects, so they are very, very careful in prescribing the chemotherapy. So that could be a reason why the chemotherapy was not given according to protocol. Again, no difference in complications, surgical complications between the two groups. So if we look at the results of the ESOPEC trial, first of all, Matthias already mentioned it, it's still not published as a full paper. So we don't have all data available, but we know that the baseline staging did not require a PET, that there was a large randomization, a large dropout after randomization in the cross arm. There was no RTQA. And then we still don't know what patients were exactly included in the trial. Were these esophageal adenocarcinomas? Were these GE junction adenocarcinomas? Were these what we would call gastric cancers? We have no idea about the sievert distribution. There is a high protocol compliance with FLOT, but there is a very low protocol compliance with CROSS. And then there is no immune checkpoint inhibition in the cross arm of the ESOPEC trial. And with that, I would like to finish my short overview of the 2 trials.
Karin, many thanks for the overview, and many thanks in particular for putting it into context and for the discussion. If you have any questions, please use the questioning and answering. Maybe I can start with a question. You mentioned the compliance issue in the TOPGEAR trial as well, that there was slightly worse compliance for the post-operative chemotherapy in the pre-operative radiochemo arm. And there was also a slightly, it was only 5%, but 5% less curative resections and 5% lower proportion of patients receiving surgery in the neoadjuvant. Was there any association with the radiation being delivered, quality assurance? I think 3D conformal, IMRT, and VMAT was being allowed. So was there association between, let's say, modern radiation and compliance to systemic therapy and surgery? Has that been investigated?
Yeah, it has been investigated. There is a paper published in the Red Journal where you can find all details on the RTQA, because 70% of all cases were reviewed pre-treatment. There was no difference between the different techniques used, but I must admit that the volumes today we would probably choose a somewhat smaller volume to irradiate in the pre-op setting. So it was quite a large volume. The elective nodes that had to be included in target volume were quite extensive.
Another question mentioned in the chat, which I would also have asked, the patterns of failure was quite interesting in TOPGEAR. I mean, we have seen local efficacy based on the response and also based on PCR rates, but looking at the patterns of failure, it was absolutely identical. There was no decrease in local regional failures. Do you have any explanation for this also kind of a bit unexpected result?
That's a difficult one. It's also the case in the neo-Aegis, where we see exactly the same. And the discussion of that in that paper is interesting. It's probably because the very good local response is not counterbalanced by the high risk of distant metastasis in this disease. So that does not mean that chemoradiation does not have a role, because it improves our zero resection rate, and we know that patients that undergo an R0 resection have a better prognosis. We also know that patients that respond well to pre-op chemoradiation have a better prognosis. But because of the high risk of distant metastasis, you might need a lot of patients to show this, and it certainly points into the direction that we need to intensify treatment so that we tackle the two problems, the distant metastasis and the local regional control.
There's also a question, thanks in the chat, and I would have asked as well. I mean, when you showed the forest plot for the subgroup analysis, I was a bit surprised that you said there was no kind of signals for better or worse efficacy. But when looking at the GE junction, it appears at least that the patients having the GE junction tumor location might have a benefit from the preoperative chemoradio with a hazard ratio of 0.78. Obviously, the trial wasn't kind of powered on that. And but what is your interpretation of this, let's call it observation?
My interpretation, but it's only my interpretation, and my experience is that for GE junction tumors, it's, between brackets, easier to irradiate it. There is much less motion. It's better tolerated. So, but we have to be careful, because the neo-Aegis is negative. It might be that it has to do with the location of the tumor, which makes it better, easier to target than a gastric cancer, although the protocol was very strict. Patients had to be sober 3 hours before they were irradiated. Imaging had to be performed. Yeah, I don't know. I don't think we can say that GE junction adenocarcinoma is more sensitive to radiotherapy, because then we would see it in all the other studies as well, and we don't see it. So yeah, I have no clear explanation for it.
Maybe one last question. The neoadjuvant radiochemo arm, if I remember correctly, used one cycle less chemo. So effectively, one chemo cycle was being replaced by radiochemo. If you would have designed the trial again, would you say this could have been the explanation? So for the lack of benefit, that it was effectively an escalation from the local treatment perspective, but a de-escalation from systemic therapy. And as you mentioned, that could have kind of counterbalanced the potential benefit effect of local by potentially decrease in systemic efficacy.
Yeah, I think you are absolutely right. Also, patients that got pre-op chemoradiation, less patients received post-op chemotherapy. So the way to go, in my opinion, is to to improve the systemic treatment. I'm not sure it will come from chemo only. And yeah, that phase 1 trial I was alluding to that was looking into a shorter course of radiotherapy, somewhat higher dose per fraction, but then combined with immune therapy and chemo in the interval to surgery. So like in rectal cancer, start with the chemo radiation and continue with the chemo till the surgery. But it's clear that we have to intensify, we can only efficiently intensify, I'm afraid, if we move to the pre-op setting, because in the post-op setting, well, there is no room for intensification, as it is already very hard to treat patients in the post-op setting.
And as you mentioned a couple of times, we are still at a 3-year overall survival of 50 to maximum 60%. So there's certainly room for improving. And you've shown the efficacy in terms of local PCR and major pathological response. You mentioned the opportunity of achieving a PCR in patients which are unresectable. So there's good rationals and good kind of potential patients which could be included in future clinical trials. So with that, I would like to finish. We're slightly behind time, but it was a very important topic. Karin, many thanks for putting it into perspective. Many thanks for joining, everyone. Wishing you a peaceful time, hopefully before Christmas. I guess no one is having really peaceful time. We're always running around, kind of trying to finish everything up. So thanks for taking the time for our lectures and have a fantastic evening. Thanks for joining. Bye, everyone.